It utilises the interval between the deltoid supplied by the axillary nerve and pectoralis major, which is supplied by the lateral and medial pectoral nerves. In terms of structures at risk, the brachial plexus and axillary artery run underneath the pectoralis minor muscle towards the upper arm on the medial side of the conjoined tendon of coracobrachialis and the short-lived biceps. Entering the conjoined tendon on the medial side, approximately 5 to 8 centimeters distal to the coracoid, is the musculocutaneous nerve, and this is at risk from over-vigorous retraction. Mark with a sterile marker pen your landmarks, which are going to be the edge of the acromion laterally and your coracoid anteriorly. You make a 10 to 15 centimeter incision which heads towards the humerus for trauma, and typically for elective surgery this is going to be more vertical. After making the incision, the skin, you would then diathermy any bleeders in the fat, and you then want to identify the deltopectoral groove and find the cephalic vein. And we can see that the cephalic vein typically goes laterally because of most of the tributaries being on the lateral side. Retract the deltoid laterally, and this will then bring into view the clavipectoral fascia, palpate the coracoid process, which is your next major landmark, and we then incise the clavipectoral fascia on the lateral side of the conjoined tendon, which is the safe side. Depending on whether this is a trauma or elective situation, this will affect how we proceed. In a trauma situation, there's often a lot of distorted anatomy because of the fracture. We need to look for the transverse fibres of subscap and the long head of biceps, which is going to be our next major landmark for placement of the phylos or proximal humerus interlocking plate. Typically, if there's a head-splitting fracture, which is into the intertubercular sulcus, the long head of biceps can be trapped in between the tuberosities. An elective situation, we need to divide the subscapularis in order to gain access to the glenohumeral joint. So this would be by placing stay sutures into the subscap. We can identify the anterior circumflex humeral vessel and the vena comitantes, which forms the three sisters, and we'd make a straight vertical incision. We can see we've got our stay sutures in subscap tendon, pulling it out of the way, and we then make a capsulotomy vertically. Whilst we're doing this, we need to be conscious about the axillary nerve, which runs in very close proximity. By placing the arm into external rotation, this is going to move the axillary nerve out of the operative field. We need to make sure we've got adequate exposure by releasing the capsule all the way around. We can use a Bankart retractor anteriorly in front of the glenoid or a skid passing through the joint to lever the humeral head out of the way.